Okay, hi everybody. This is Dr. Ed Park from Recharge Biomedical, and today we're going to be discussing vision, which is really one of the most amazing gifts we have. So the goals of the talk will be to talk about how vision works, present two cases of improvement, speculate a mechanism, and then discuss whether this is something that you would want to try. Before we move on, let's talk about the eye. The eye, first of all, in that black circle in the middle is the pupil. The pupil is not a thing. It's just a space created by the other thing. So there is no pupil. So let's look at it from the side cross-section here. What is the eye? The eye is, of course, the covering, which is the cornea, and the white part of the eye is the sclera. We have the iris, which is the thing that opens and closes in response to light conditions. And behind that is the lens. The lens is what gets cloudy and stiff as we get older, leading to cataracts and presbyopia, or the need for reading glasses. Behind this, there's this gel in the eyeball itself, and at the back is the projection screen, or the retina. And then the nerve has to leave, and then we have these muscles attaching and moving the eye. Of course, we like the eye to stay moist, so we blink. We like it to track together, so we have synchronization of these eye muscles. And a lot can go wrong, so let's get into what that exactly looks like. All right, so the first really cool thing is that your eye reacts to brightness. Of course, you know, the doctor will have a little pen light or test whether your eyes react equally. That's important because brain damage can cause unequal or fixed or dilated pupils. When people are relaxed or even sexually aroused, their eye gets dilated. That's called mydriasis. It's shown above me. When they're on cocaine, it gets pinpoint, or when they're excited or very stimulated, it goes the other way to meiosis. Just as a camera has an f-stop, which lets in more or less light. The more light you let in a camera, the greater the depth of field, and the shorter you need to expose the film. And that was interesting stuff. Now let's look at what happens when you shine a light. When you shine a light in the eye on the left, you can see that there's a reflex that goes to the brain, and the brain says, "Ooh, too much light, let's close it down." So how does it do that? It constricts with these circular muscles, making the opening, the pupil, small. And when there's not enough light, your eye brilliantly opens with these radial muscles pulling the curtains open, and so you get a dilated eye, and that's really, really cool. Okay, so everyone should know about myopia and hyperopia. Myopia is just everything far away is blurry, and hyperopia is you can see far away great, but you maybe can't see stuff close up. And so it's just a simple matter of optics. And Sir Isaac Newton was really into optics, as well as other cool things like gravity and calculus. He used his quarantine lockdown time well, but anyways, so the point is myopia, you got an image, the light rays come in through your eye, through the cornea of the lens, and they focus. Okay, ever remember playing with cameras and focusing? There's only one setting where it's in focus. And in the myopic eye, the eyeball is too long. It's like a football. So the focus, the focal point happens before the back where it's supposed to happen. So you got to wear corrective. These are not corrective, but back in the day when I had 7, 8 diopters, minus 7 or 8 diopters, it bends the light outward, I suppose, and allows the light to focus exactly on the retina where it should. In farsightedness, these people can see very well, but they can't see close up because the light image focuses behind. In other words, their eyeball is too short. So that's corrected by bending the light inward. And that's a plus prescription. That's why you walk into Walgreens, you get readers, +1, +2, etc. Those are diopters. Okay, so those that did photography know that there's something called a macro lens. There's a telephoto lens that allows you to see far away. There's a macro lens that allows you to see close up, like this macro lens is showing with the mushrooms. So again, as we said, that takes the light rays and bends them closer. So what do we have when we get older? We young people, as shown in this graph above me, age 0 to 10, They can go up to 12, 13 diopters of macro focus. They can see very close up. But older people, once we hit about 50, really it's very, very little accommodation takes place. Accommodation is the macro lens. The macro lens means that the lens itself is a soft, clear gummy bear. Okay? And so when the muscles are contracted, the gummy bear flattens. Okay? If, however, we need to read something close up on a condiment bottle or whatever, what happens is the muscles contract, relaxing these fibers, and the gummy bear, if it's soft and gummy, it will become rounder and more refractive. So that allows us to read close up. And when we get older, the lens is less gummy and it's more stale, and therefore we cannot read close up. Finally, continuing with the camera analogy, it's like film. You project onto the back of the eyeball. So the terms are: the macula is that general area towards the center of the eyeball. In the center of the macula is the bullseye, the target is the fovea. And that's where a lot of the fine vision takes place. A lot of this other stuff you see is it's just kind of movement, light, color. But the real ability to focus and determine what's going on is in that fovea, the tiny, tiny little area in the center of the macula. And so what do we have at the back projection screen? We have rods, which are highly sensitive. Even a single photon of energy will be sensed by the rod. So that's good for low light conditions, for movement, black and white, I guess. And we also have the RGB system, interestingly. We have red, green, and blue cones. These cones are specialized. They look like cones, as shown in the cartoon in the middle above. And they can perceive different colors of light. And when integrated together, this gives us the ability to see, which is an amazing thing. What we have here in the graph is the prevalence of macular degeneration. So this is much more common in people of European descent, but this is basically another age-related condition. And if I had the octagon, which I usually show, it would show that all our bodies are made up of cells from stem cells, and those deteriorate. So no exception with the retina. The retina has what we call retinal pigment epithelium cells, and they're producing these cones and rods. And so as we get older, we lose the ability to see. And the what looks like a graph to you and I, to a person with macular degeneration, looks like wavy, jiggly, watery problem. So, okay. So finally, the eyes are also trackers. They follow. So when we do a brief neurological exam, I hold out my finger, have them follow. They should have no lazy eye. Both eyes should be together. They should track. And this tests 3 of our cranial nerves, 3, 4, and 6. So what we see here in the cartoon at the upper left is that 3 is green. Those are the muscles that do those movements, also represented in the eyeball below. 3 is cranial nerve 3, ocular motor nerve. And then we have cranial nerve 4. And then we have cranial nerve 6. And these are the ones that move around the eyeball so wonderfully. When we have what's called strabismus, or non-alignment of the eyes, strabismus. We can be cross-eyed, which is esotropia. That's the one in the bottom right. We can have exotropia, which is eye going out, hypotropia, and hypertropia, down and up. So any lack of alignment can exist. This is usually not because of an ocular motor thing per se, but because we have eye dominance. So let's take a moment to talk about eye dominance. If you take your hands and make a triangle and focus like an object in a room, you close one eye, you close the other eye. The eye image that doesn't move is your dominant perceptive side. So I'm left eye dominant. So this brings up a very important point, which is that we always have double vision. Okay, double vision is shown to my left. It could be up, down, sideways, whatever, but we always have double vision. And that's why people with a pirate's patch or one eye have poor depth perception, because in our minds, we're getting 2 images all the time. It's just that we're actively suppressing one of them. Do you see? So a double vision is a fact of life. It's just our brain learns to ignore one side. Now we put it all together. We got the optics, the focus, the light, the brightness. We got the uh, two images, and somehow the brain is able to put it all together. Um, what we see here in the lavender and the lime sort of coloring is that uh, this is from below. The right side of the brain perceives um, the left visual field. The left side of the brain perceives the right visual field, just like the right side of the brain controls the left side of the body, etc. And this will be important in one of the cases we present. So you're always getting things or signals from both eyeballs, but the processing is specialized in one side or the other. Just a call back to last week's webinar on prosopagnosia, a woman who had some pretty severe inability to recognize faces, which was acquired during pregnancy, strangely. And I wanted to just refer you back to that because when we talk about vision, it's not just light hitting the retina and the rods and the cones, but it's also higher order understanding. So actually, the brain, the consciousness is how we interpret the world. If people are on hallucinogens that reduce the ability for people to differentiate themselves from the world, they can have strange perceptions because they no longer view it as subject object, right? So when we lack the judgment, the bias, the prejudice of seeing, this is what happens. So when we talked about aperceptive versus associative agnosia or face blindness, prosopagnosia, we need to know that vision is not just seeing, it's actually interpreting. So this is a great illustration of what aperceptive or non-perceptive face blindness or visual blindness is. If you tell them to copy an A, they might do these squiggles, or B, an X. They just can't do it. A circle might turn out like that. Whereas they can't perceive. They're aperceptive, right? Whatever is processing the brain, sort of like Wernicke's aphasia versus Broca's aphasia. Wernicke's aphasia is they can't even understand the language, whereas Broca's aphasia, they can't form the language. Whereas a person with associative prosopagnosia or visual blindness, they could copy something like a tea bag or a pen beautifully, but if you ask them to say what it is, they don't know. That's a different part of the brain that's glitched out. So again, I refer you back to last week's talk on face blindness. So we're going to present two cases, both of which share brain damage. So what is brain damage? Well, it is what it is. It's not anything very complicated. When we look at this cartoon of the brain in cross-section in a sort of sagittal frame, what they're trying to illustrate is that there's a circle of Willis. A circle is formed which feeds the whole brain with arterial nourished blood. So coming up from the spine, there's the vertebral arteries which fuse into the basilar artery, and then there's two carotid arteries in the neck, and this pumps and feeds the brain. When you get a clot forming either down below and lodging up in the ever smaller arteries or in the artery itself, you have what's called infarct. There's no blood, the brain dies, as shown in this MRI. The MRI shows two different weighted images, and basically there's mass ischemia or tissue or cell anoxic death. The other kind of brain injury, or there's many kinds, infinite kinds really, is impact. So you have a coup and a contra coup. The brain is in this gelatinous case. It's soft, it's spongy, and so when you stop moving, but your brain keeps going, you get a deceleration injury. It's a coup injury, right? You hit the dashboard. And then what happens is the brain rebounds back, as you can see in those crash test dummy videos, and you get injury on the backside too. That's the contra coup injury, massive cell damage and loss of function. So let's present our two visual change cases. One is DK. It's a 59-year-old man with a 5-year history. He had a stroke 5 years prior. I met him just by serendipity at a conference, and he wanted to take the telomerase activators. Of course, FDA has not approved exosomes for visual problems, but he wanted to try it after informed consent. His history is notable for having a 3-month coma. He had a witnessed stroke, which resulted in left hemiplegia with spasticity and complex regional pain syndrome, meaning he's constantly in pain on his left side. So he had a big hit to his right brain. A lot of cells died, a lot of function was lost. So back in July last year, we did just 2 billion nasal exosomes from mesenchymal stem cells. And overnight, he had improvement in one aspect. I hate to say that his spasticity and his pain didn't ameliorate that much, but one thing that was notable was that his left homonymous hemianopsia improved, which means that if we go back a slide or two, Paris looked like this to him. I guess in the opposite way, he could not see this whole Eiffel Tower, the left side. The right side, perfectly fine, no problem. Left side is just absent. And again, that is illustrated here in picture 3. So picture 3 is where DK's problem was. You can see that, and neurologists love to do this, depending on the clinical signs, you know where the lesion is, which is basically the whole thrill of neurology. So, of course, if you hit the optic nerve from the eyeball before the chiasm, you get one blind eye. That makes sense. Like you remove an eye, you can't see out of that eye. But remember, the visual fields are comprised of images from both retinal hemispheres. If you mess up the chiasm, which is the crossing or the decussation of the fibers, what you get is bitemporal hemianopsia. This is a classic thing when you get a pituitary tumor presses up on the chiasm or the cross. That's Greek for X, and then you can't see out here. If you have a lesion at 3, which is what DK had, you can't see 1/2. So if you start to hit the lesion after the differentiation between superior and inferior, you can have the 9 to 12 quadrant or the 6 to 9 quadrant. So we know where the lesion was, and we know what cells probably recovered to some small extent, meaning that he recovered the ability to see shapes and movement, which was something. It's not nothing. Is it 20/20 vision? No. The second patient I wanted to present to you was MF. She's a 75-year-old woman with a history of traumatic brain injury. As about a 21-year-old, I think, she drove her car off a cliff, and she awoke days later in a coma. She had been thrown from the car. It saved her life, I guess, and then she had broken bones everywhere and terrible brain trauma and problems since. Interestingly, on exam, she has no strabismus, meaning there's no lazy eye, and there's no monocular diplopia, which means double vision in one eye. Double vision in one eye is a totally different non-brain thing. When you have double vision in one eye, it's not pathways, it's some warped cornea or lens. Something strange is going on. So back in April of last year, she received 5 billion IV exosomes, and it was mainly for shoulders or legs, just general health. But what she did notice is that her double vision resolved and remains gone to this day. So why does this occur? Well, she had brain damage, and we see the visual cortex is that sort of celadon-colored area in the back, and there's 2 gross things that it does. The pathways going down, as we mentioned with face blindness, are the ventral or down visual stream to the occipital temporal area is what am I looking at? And then going up is the where is it? The parietal lobe is more of like spatial relation, I guess. That's how they broadly conceive of it. This picture above me shows just some pathways that they did. They took a look at through functional MRI, and they tried to infer back the different known regions of the brain. And they said that when a person is able to basically suppress one of the 2 images, you don't have double vision, and that the brain function is different in people who do have double vision. So there is a lot of higher order stuff going on besides just the optics of seeing. It's the interpretation that makes it such a rich experience. So just wrapping up, I just want to review for people that don't know, because I'm sure there are some people who don't know. Here on the scale of things is the hydrogen atom at the Planck length down up to the giant sequoia. We're talking about exosomes are the product of cells, particularly in this case, mesenchymal stem cells, and they're about 1/300th, maybe 1/500th the diameter of the cells. They're tiny, they're not cells. They don't have their own cell machinery or DNA, so they're just messages sent, and they don't have self antigens, which means that we can all use them without having an immune reaction and destruction. So the final slide is, how would any of this be working? Well, of course, it's just speculation. It could have to do with remyelination of the nerves. Um, it might be just anti-inflammatory. It could be having to do with regenerating damaged cells via dedifferentiation, which we talked about in the webinar on nerve damage, apoptosis, or programmed cell death, allowing certain cells to die, like live wires, those cells die. And then finally, I wanted to just bring up the fact that, I have keratoconus. That's why I wear these. I had a LASIK 20-something years ago, and it took off too much of my eye or my cornea. So I have dryness because the innervation is poor. I don't know when I need to blink and keep my eyes moist. That's why you see me blinking a lot. And then the surface of the cornea, not the lens, is warped. So occasionally, if I ever find it's like a drop, I'll put some in my eye. Hopefully that'll help with that. Cataracts, of course, are a very common problem in people, especially in places like where I'm at now, Hawaii. There's a lot of sun, a lot of damage to the UV. You see what it does to the skin. It does the same thing to the lens. Presbyopia is a function of poor lens plasticity. That gummy bear is stale and yellow. And then age-related macular degeneration, again, maybe just an aging disease. Hopefully we can get some way to deliver exosomes and maybe see if they could help in that way. So if you have any questions, email me at drpark@rechargebiomedical.com. Go to my website, learn much more about exosomes, and link to the videos and the blogs. So again, just a brief webinar. You want to stop sharing now and see if there's any questions. This was just a real fun, quick review on vision because I think it's interesting. People don't realize that doctors don't know everything. They just have to learn everything, and then they forget most of it and have to relearn it. So that's one of the great privileges of doing these webinars, is I get to relearn. All right, if anybody has a question, you can type it into the chat, raise your hand. I can unmute you, or I can attempt to answer it. Okay, we have a question. Richard Brewster types, how much does a series of injections cost? Well, it depends on how many exosomes you get and by what method to some extent. I don't know if I'm unique in this, but if you buy the exosomes, I'll generally use them as you instruct. So, we could do multiple procedures off one vial of 5 billion. I think the price varies in the market. If you're talking about 5 billion, people generally charge around 2,500 to 3,000. But if you buy subsequent vials, this is the Chimera brand only. There are other brands, but if you buy other vials, the price will go down, and the efficacy will go up as well. The question follows up, how much do you recommend per year? I don't know if I would recommend any per year. It kind of depends. If you're an 18-year-old person, probably none. If you're a wealthy 80-year-old, you could make an argument for a lot. As a way of maintenance, probably people are doing 15 billion every 2-3 months to stay young. I just heard about a guy who bought 70 vials, who wanted to make sure he had them in the freezer in case they were no longer available. I want to talk about this concept of low-hanging fruit. A lot of times we do see improvement in severe neurological conditions overnight, and it's sometimes cured. Other times it's just made better. But, I just had the experience of third treatment of a patient, 50-year-old, who I discussed in the stroke rehab webinar. The first 2 times she did the procedures, she had significant changes, new movement, new sensation. etc. But the third time was not the charm for her. So the question is, have we gathered all the low-hanging fruit? Is that it? Is that the end of her journey? Do we need an increase in dose, increase in frequency, or is this all the benefit she's going to get? We really don't know. So I always encourage people. I hear these stories where people did something repeatedly without any kind of improvement. I wouldn't say that's a good idea. But once the improvement stops, perhaps it's time to stop. So the question is, well, if I told you you're going to spend X thousand dollars, 3 treatments, you only get this far, would you have done that? Most people, yes. Some people, no. But we really don't know where the benefits stop or if they stop. So all of it is quite empirical, and you have to adjust based on heuristics. All right, everybody, thank you for joining our webinar on vision. And next webinar will be in 2 weeks. Perhaps we'll do hair restoration, autoimmunity. I've not decided. But if you missed any part of this presentation, I'll repost it to YouTube. And again, thanks for joining. We'll see you next time. If you have any questions, feel